Good afternoon, everyone. Welcome to Articulate Health Economics to Support Understanding of Microeconomics. Before we begin, I would like to acknowledge the traditional owners of the land on which we meet today. I am hosting this webinar on the land of the Darug people and pay my respect to their elders, past, present, and future. My name is Meg. I work as an external engagement officer at the Faculty of Arts and Social Sciences at the University of Sydney. Thank you so much, everyone, for joining us, and I hope everyone is safe in this extended lockdown. This webinar will go for about 45 minutes, around 30 minutes talk, and there is a Q&A session at the end. Please feel free to pop your questions in the Q&A in this Zoom at the bottom where you can find it. And Dr. Rebecca McKibbin will answer the questions for you. So I would like to introduce our presenter for the webinar. So Dr. Rebecca McKibbin is an applied microeconomist. She teaches health economics and labor economics at the University of Sydney School of Economics. Her research examines the adoption of science into medical practice and how this impacts population health. Prior to completing her PhD at Yale University, she was an economist at Deloitte Access Economics and the Reserve Bank of Australia. So please take it away, Rebecca.
Well, thank you, Meg, for that introduction. So what I wanted to do today is give you a brief introduction to health economics, which is my personal area of interest when it comes to my research and also a subject that I teach. So if you chose to come and study economics at the university, when you're in approximately your third year of your studies, you'll be able to select some elective subjects that allow you to dive more deeply into particular areas of economics. And health economics is one of the courses that you could choose to take. And so even though health economics is typically taught at a more advanced level in the economic curriculum, essentially it is building off the exact same basic economic principles that you learn in your introductory studies. And so I think there's a lot of interesting things to study on this topic, particularly at the moment while we're in the midst of this global pandemic, and health and the economy and how it interacts is coming up a lot in public discourse. So let me just start off by giving a simple definition of what health economics is. So health economics is simply applying economics, both in terms of concepts and methods, to the study of how individuals and or societies allocate a scarce resource towards health or healthcare. And with health being our ultimate outcome of interest, healthcare is an input into that outcome of interest. And as we can observe, just by looking around the economy, we know that healthcare is a very sizable industry, and it's also a very complicated industry where there are a lot of issues with competition functioning, so that there's a big role for economists to examine policies to help support healthcare markets to operate. So it's a really large area to study. So today I'm going to focus more on health and why we're looking at health. If there's time at the end, I'll talk a little bit about healthcare markets, although this itself could be the subject of an entirely separate talk. So why are economists interested in health? Well, economic problems basically come down to one simple thing. We're trying to look at how we can maximize our well-being, or utility as we call it in economics, given the fact that our resources are constrained. We don't have unlimited resources, so how can we spend these in the way that makes us the best off that we can be? And typically when we're learning our introductory economics, we think about our utility as being a simple function of our consumption, and sometimes a function of our consumption and our leisure. So things that we buy and just the way that we spend our time and whether it's enjoyable. What we do in health economics is we break this down a little bit further, and we explicitly acknowledge that health plays an extremely important role in our well-being, our physical and our mental health. And so health is an extremely important component of utility. And by explicitly acknowledging how important health is to our utility, it makes it very logical that we should study how allocating resources impacts our health. So health, I would argue, is an extremely interesting subject to economists. So is there a role for economics in understanding health? Why do we want economists and their allocation of resources focus thinking about our health? Why not leave that just to the medical experts? Well, again, let's unpack what health is and think about how it relates to our resources. So if we start off by thinking about health and what drives our health, we can break this down into a very simple model. And of course, we use simple models in economics to illustrate points. They're not supposed to be comprehensive models of how the world actually works. They're supposed to just be simplified. So if we think about our health, I like to think about our health as having two broad inputs. Our health has some element of luck, so things that we can't control, and things that we can control. So things that we can't control is things such as just out of nothing to do with any of your behavior. Maybe you will come down with a particular disease. Maybe you'll be born with some predisposition to get sick with a particular condition. Maybe you'll be in an accident while you're walking down the street. These components of your health are more or less outside of your control. But a big component of your health is inside your control. And this is supported by a big body of medical research. And what is inside your control is your lifestyle. And lifestyle factors play a really big role in our health. So if we think about lifestyle factors and break them down a little bit further so we can consider how they impact our health, I just put forth these broad categories, but again, not supposed to be completely comprehensive. So we can think about some things that we can control, like whether or not we smoke, how much we exercise, how healthy we eat, and to a slightly lesser extent, what medical care we choose to seek out. And so all of these factors have something in common, aside from the fact that we can choose how much to do them or not do them. And that is that they use up our resources. They use up our resources both in terms of our time and in terms of money. And so once we start thinking about time as being a very scarce resource, and the fact that living a healthy life does take up our time, and it also takes up our money, things like eating healthy food can be expensive, we start to see that health does have a sizable component that comes from how we choose to allocate this scarce resource of money and time. And as we know from our Economics 101, our money and our time has an opportunity cost. So if we choose to spend it on health, we're going to have to take away those resources from other things that might contribute to our well-being. So a really important point to take away from this, which I think follows logically out of the simple model that I just showed, but has also been shown to be true through research onto the real world. And that is that the biggest determinant of your health is not your medical care, but your economic circumstance. So of course, medical care plays a big role in improving health when you have particular conditions or illnesses. But when we look across history and when we look across groups of people in our society, and when we look across countries, the single most important thing that explains why some people live longer and healthier lives is how much income they have. And so I think that it's a really important message to take away into why we need economics when we're thinking about our health. So briefly, just to expand on that model a little bit more, the way that economists think about health is not as something you consume. So we don't think about health as something that every period you decide how much health you want and then it's gone, and next period you remake that decision. We think about health more like it's a machine or like a capital good. And so here, I hope you can see my cursor. I've drawn a very stylized figure of how we model health in health economics. And basically, you start out when you're born with some stock of health, some amount, and then over your life as you age, that health deteriorates. And it starts off deteriorating slowly, and as you get older, it tends to deteriorate more rapidly. And so that's just like a machine depreciating. Now, to continue with the machine analogy, if you want to, you can spend some of your scarce resources in maintaining the machine or maintaining your health. So here's an example. Imagine around the age of 10, sometime in childhood, you decide to invest some of your resources into improving your health. When you make this investment, it doesn't just pay off today. It in fact shifts out the decay of your health at every point over time. So you can essentially improve your health over your entire lifetime by investing in your health today. So health can be maintained, and maintaining your health has a payoff, not just today, but a cumulative payoff over your entire life. So this is similar to how we also model investments in education and economics, if you've had an opportunity to study that. The second important point in this model, which I haven't illustrated here, but I'll just make to you, is that when you're deciding how to allocate your time, which is your scarce resource, we can break this down into 4 kinds of activities that you could spend the time on. So the first one is you could work. If you work, you can earn money, and that allows you to buy other goods and services or invest in health, which improves your well-being. You can spend the time doing things that don't produce money, but that you like. You can go and spend time with your friends and family. And that's a completely valid way to spend your time, and it contributes to your overall well-being. The third option is to spend time doing things that specifically improve your health. You could go for a run. You could spend some time cooking a healthy meal. And then lastly, and importantly, you can waste time feeling miserable and sick. So in this model, where we have a component of your time that goes towards being sick and doesn't contribute to your overall well-being, what happens is, as your health deteriorates, if you choose not to invest in keeping your health well, that amount of time that you have to spend not improving your utility, or what we call productive time, that increases as you age, or increases as your health declines. And so what this means is that not only is your health today and in the future getting worse, but the time that you have to do anything that improves your utility or your overall well-being goes down. And so that means that your entire lifetime utility function or your entire lifetime well-being declines and shrinks as your health gets worse. So 2 people who have different levels of health have different overall capacities to, I guess, generate well-being throughout their life, depending on how they've invested in their health. And so this brings me to, I guess, the second key message of health economics. And that is that health isn't separate from the economy. In fact, you could argue that health really is the economy. And we can dive into this a little deeper in the following way. So first of all, let me stop and take a minute to say, what is the economy? We talk about the economy all the time. Often we learn about the economy as being GDP. But what I would say is that the economy is basically the place. I say place in inverted commas because it's a hypothetical place. It's the place where people come together to exchange resources in order to maximize their individual well-being, which includes their health. The way that we measure this economy is by somehow aggregating everybody's individual well-being. So you could say the economy is an aggregation, or a measure of the success of the economy is an aggregation of everybody's well-being. And if we want to measure this and be able to talk about it in a quantifiable way, we need to include in it things that we can measure, which is where we get GDP as our measure of well-being. So we're measuring or attempting to measure all of the trading that happens in the economy. We're summing it up the dollar amounts, and then we're looking at how large that is relative to some other point in time or when something else is happening. But this doesn't mean that health isn't part of the economy. It's just that health is very difficult to measure, and so it tends to get left out of the economy. But conceptually, the economy is a sum of all of our well-beings, and so therefore, the stock of health is the economy. And so let's go back to our simple model and think about how this occurs, just to drive the point home. So you could start anywhere because it's a circular thing, but let's start with income. People who have more income, they can invest more resources in improving their health. When your health is better, you have more time to work and do other things that improve your well-being. But let's focus on work, since we were just talking about GDP and how it relates. So if you have better health, you can work more. You can work more. If you work more, then you can earn more income. This is going to improve our measure of economy in terms of GDP, which we know tends to result in greater opportunity for people to earn income. So as health expands in the economy, as health expands in the population rather, the economy is also expanding because people have more time or more productive time that they can use towards doing economic activity. So whether or not we even explicitly think of health in our simple model, health leads to a larger economy. Having a healthier population leads to a larger economy. And if we wanted to contrast that, we could go the other way and we could say, what happens when health gets poor? Well, when health gets poor, there are going to be more people who don't have the capacity to work and earn income. And so when some people don't have the capacity to work and earn income, then as a society, we tend to support those people using money that we get from taxation. So we take some income away from the people who can work and we give it to the people who can't work to make sure that everybody has some basic standard of living. And when we do that, that means the people who are healthy have less income to spend on maintaining their health, which leads to their health declining, which leads to more people not having the capacity to work, which further shrinks the economy. So you can see that this is a very circular thing, and how much health, having a healthy population is really fundamental to maintaining a strong economy. So the reason I wanted to talk about this today is I feel like in public discourse, health and the economy have kind of become enemies. And I wanted to try to address how has this happened? How did health become how did the economy become the enemy of health when health is in fact really what the economy is based on, at least if you take a health perspective. And so I think this comes from a misunderstanding of how we think about the allocation of resources at a societal level. And so we'll come back to the answer to this question because I'll first explain this concept. So I'm sure most of you will have studied some kind of concept of how individuals are going to maximize their utility subject to their budget constraint or their resources. This is an individual level problem, and it's usually one of the earlier things that we learn in economics. But in many situations, we're going to need to think beyond the individual and consider how a society should allocate its resources for the purpose of furthering the well-being of the entire population or the economy. And so if we want to do this, if we want to evaluate the economy or think about policy, what we need to do is we need to work out a way to basically aggregate everyone's individual well-being into some kind of group measurement, and then we need to maximize this relative to some kind of resource constraint. And this is where things get tricky. So economics is very focused on what we call efficiency. Efficiency is when you don't leave any unrealized gains from a trade. So you might have heard of this as when the marginal benefit equals the marginal cost. So when you have supply and demand coming together, the market clears and there's no deadweight loss. And another way you can frame this is you're trying to maximize the size of the pie. So we want to make the aggregate well-being as big as possible. And the idea of this is that if the pie is as big as possible, then we can cut it up in some way where everybody is better off than if we'd made the pie smaller. The problem is that there are an infinite ways to slice up that pie. And so I think a lot of the debate of health versus the economy is actually about how we're slicing up the pie. So when you want to slice up the pie, economics is fairly agnostic on this. Economists like to not take a stance or say they're not going to take a stance on what's fair in society. That's up to the politicians and the bureaucrats who make policy. The problem is that, so in theory in economics, once you've made the pie as big as possible, any way that you cut it up is still efficient. And we can achieve any of these allocations by simply taking resources from one group and giving them to another group. And that will keep the pie the same. We just give some more pie, take some pie from someone who got more through the market allocation and give it to someone who got less, and problem is solved. The problem is that creates winners and losers. And so as soon as you have winners and losers, the people who are going to lose from this reallocation are going to be unhappy about it, and they're going to start complaining. The second issue is that whenever you do this kind of reallocation, it tends to be inefficient relative to just leaving the allocation as the market gave you. So it's not really possible in real life to keep the pie the same size and then share it around. You always lose some crumbs once you start cutting it up. And so how did the economy become the enemy of health in public discourse during this pandemic? I think what people are really fighting about is how to divide up the pie. So most economists actually do agree that the best thing to do for the economy in terms of COVID is to keep COVID as low as possible or completely get rid of it. So fighting COVID is best for the economy as a whole. The problem is that when you just bring in a blunt instrument policy like a lockdown, you get into a situation where the costs aren't being shared equally across society. So you have some people suddenly being made a lot worse off than other people. And so, of course, people are going to start arguing about whether that's fair. And they might not be framing it as whether or not that's fair, but that is more or less what the fight is about. And when you're making this argument, if you're in a group that has lost more than another group, you could make what I would say false argument where you say, look how much it's costing the economy, by which you mean the pie is getting smaller because of what you just did. But what you're actually doing there is you're measuring the costs that can be measured, so in terms of the amount of trade that's actually going on, but you're not including the benefits to health, which are also part of the economy, but they're extremely difficult to measure. And so the issue with this debate is that you're really asking the wrong question. You're asking the question of whether or not we should fight COVID, when what you're actually wanting to have done is have it be fought in a fairer way. And there are lots of ways that we can address the inequality that's arisen from policies like lockdowns, and that we have addressed through policies like JobKeeper and JobSeeker. So essentially taking from those who have been hurt less by the lockdown and giving to those who are hurt more, so particularly in the form of workers. But this doesn't mean that we've put the distribution of our societal resources back to what it was before we had the lockdown. And so when it comes to deciding whether or not we should sort of continue to redistribute and what's fair, we really need to consider the question of what is fair. And I think I may have made it sound kind of straightforward to understand what's fair, but fairness is extremely complicated. And it's an area that economics loosely touches on, but sort of tries to avoid addressing. And what's really interesting to me in studying health economics is that you can never fully take yourself away from thinking about fairness once you start looking at problems as being trade-offs between lives. And so this is an example that I like to give in my class at the beginning to set the tone of the types of decisions that we're actually thinking about. So imagine in a medical scenario that we have something like an organ. There's just one organ that's come up, and there are 4 people who are going to die today if they don't receive the organ. And so we have to choose somebody to save. And this, you could argue, is kind of the ultimate in-your-face sort of allocation of a scarce resource that has really serious consequences, where we can't avoid thinking about this as being lives versus lives. And so here I've just put up some characteristics of the people to help make a decision. And what we would typically do in this problem is take some time just to think about, like, what should we be taking into consideration when we're deciding something such as this, who to save. And I haven't enlisted a comprehensive list of everything that you might even choose to take into consideration, but some examples of how you might think about this problem. Maybe you would like to consider how old the person is. So one way you might think about fairness is perhaps the fairest thing is that everybody gets an equal chance at having some particular length of life. And so younger people have had less life and deserve to have a chance at living as much life as somebody else. So perhaps we want to give it to the youngest person. You might want to get the most value out of the organ in terms of maximizing the economy. So maybe you want to give it to the person who's going to live the longest. Maybe you'll start taking into account characteristics of the person in terms of what they do in society. If you're, again, thinking about this from an economic perspective, maybe it matters how many people you support or what your job is or how much income you earn. Now, when you pose a question like this, actually a lot of people would vote for rolling a dice to decide. So there's a strong argument to be made that we really shouldn't make such decisions using our own personal biases, and in the absence of being able to be truly sure that we're going to make the correct decision, we should just leave it up to fate. And that's one kind of societal preference, or one kind of moral philosophy, is not to play God. Another way you can do it is the way that it's done in real life, which is essentially to give it to the person who's been waiting longest. So I guess that is about minimizing perhaps the length of suffering. But really there's a lot of different ways you could do this. And I hope you can see from this problem that it's very hard to decide once you really start sitting down and thinking about what should be taken into consideration. And the thing with the way that we make resource allocations in economics is that we're going to prioritize, firstly, things that we can measure, because we want to make this measured aggregation of our societal, of all of our well-beings, and then decide what the best thing to do is. And we're also going to be prioritizing the number that's the largest without considering, I guess, what's fair across the group. So this is not just an issue in health economics. So that was a very extreme resource allocation where we're talking about letting a couple of people die and having to pick somebody who is saved. And so it forces us to really think about more deeply about what is fair. And we could actually spend a great deal of time talking about what's fair and perhaps never coming to a conclusion. This is a big branch of philosophy that I think is fascinating. But I want to make the point that this kind of trade-off is not unique in healthcare. It's just there a bit more in our face. So let's say, for example, that we're deciding whether or not to bring in something like the minimum wage. So the minimum wage is going to basically take some of the profits of the firm, which is going to the owners of the firm, which are other people, and give it to the workers. And the consequence of this is that some workers will get more income to take home, which will improve their health. And perhaps, debatably, some workers may lose their income altogether because they'll lose their job. And then the owners of the firm will also have less income, but presumably they're also better off in the first place. But so once we're starting to move around people's income, we're playing around with their health, because when we take income away from people, or we give income to people, it impacts how much they can invest in their health. And so although we're not causing them to die on the spot, we are changing around their potential to live a long and healthy life. And so I think these kinds of trade-offs between lives, they're always there in the background. It's just that we don't have to face them when we're talking about economic questions that change around how many resources particular people in society have access to. And so this idea of maximizing the total well-being of the group, so summing up everybody's individual well-being and doing what makes the pie biggest, that's just one way of thinking about fairness in society. So when I was describing the example just before, I alluded to what's called Rawlsian social welfare functions. So an equality of opportunity, giving everybody the best chance, giving everybody an equal chance. And also we could think about a kind of societal aggregation that has a lower bound on the harm. So we might say it would not be okay to, say, kill 10 people to give 1 million people an incremental tiny health benefit. And that would be okay under utilitarianism, where you're trying to maximize efficiency. And of course, we don't need to apply these, the utilitarian idea like so rigidly that we would do something crazy that I would say is clearly immoral in order to maximize efficiency. But it's important to understand that that is the principle that is underpinning the way that we think about resource allocation, so that we can realize that somewhere we're drawing the line on what we will and won't do, and think about whether we're drawing the line in the right place before we make decisions just to maximize, I guess, the greater good. So I've given utilitarianism and economics a hard time a little bit here in how resources are allocated. And I will say that there are ways you can still use this utilitarian framework to consider other elements of well-being. So, and health economists try to do this by quantifying people's quality of life and quantifying things that impact health so that they can be explicitly included when we're thinking about what the best thing to do is for the group. And I think this is where economics is sort of heading more these days, is just, you know, acknowledging that we can trade off some efficiency in order to achieve some fairer outcome. And so you'll often hear economists say, you know, this is probably the most efficient thing to do, but it comes at this inequality cost. Policymakers decide whether you're willing to accept that. So I think we might be nearly out of time. So I don't think I'll talk about healthcare because it's a very detailed separate question, but I'll just put this up to conclude. So there are many interesting topics you can study in health economics, both in terms of just anything that impacts health. So you could study whether maternity leave is helping to reduce postnatal depression, or should we tax sugar in order to reduce, help people reduce their obesity and make better decisions about their health. And you can also study healthcare markets. So we can look at questions about public versus private insurance, and how do we provide the right incentives to encourage the development of new technology while also containing costs. And as Meg mentioned at the beginning, technology and how technology is developed and how that impacts health is the area that I spend my time researching. And we can also look at questions within healthcare systems. So for example, inside of Medicare that we have in Australia, in terms of whether or not we should change around the payments or out-of-pocket costs too high, the right things being covered by Medicare and so forth. So I guess that's my conclusion. And I'll turn to some questions now. Let's see. So
would you like to read out the questions, okay, Rebecca?
So yeah, so I think I can, is there just one question that I can see? Am I looking at the right thing?
It's 3 questions now.
Okay, when I click on Q&A, nothing is coming up.
Oh, I can read out for you.
Read them out then. Yeah,
no problem at all. So we have, I'll just ask this question. Are we looking at a single nation's economy or the global economy? Does this mean developed countries will have stronger economies if they support health outcomes in developing countries?
Okay, so that's an interesting question. Should we, I guess, typically, I mean, much like the individual tends to only think about their own individual maximization problem, countries also draw boundaries around thinking about their own country's well-being, maximizing their own group's well-being. So the question was whether or not developed countries can have a better economy if they consider developing countries. Is that correct?
Yeah, so does this mean developed countries will have stronger economies if they support health outcomes in developing countries?
So I think not necessarily. In the context of COVID, definitely. If we leave, I think it's fairly well understood that if we allow COVID to run rampant in developing countries, new variants will emerge, and they're going to spread around the world and affect developed countries. But when it comes to thinking about the world as a whole versus your personal country, that is much like the problem for rich people inside a country thinking about poor people inside the country. And so it's not necessarily the case that looking after the poor is better for you personally as a rich person. I think that comes down to a question of what kind of society we want to live in and what we think is fair in society, and deciding how we're going to split our resources based on, I guess, our ethical and moral compass. And I think that's a similar problem across developed versus developing countries.
Wonderful. Thank you so much. Yes.
Oh, I found the question. Okay.
Oh.
Okay. So the next one is, does health encompass physical and mental health, and how does this factor into the COVID debate? So yes, health definitely encompasses health, both physical and mental health, both I would say medically, but also health economists are very interested in health and mental health. And so this sort of, I guess, the physical and biological, the preservation of biological life or physical health by mitigating COVID versus the mental health has come up a lot. And I think it's a very valid and important question. I personally lived in the US for a lot of last year, and being somewhere where COVID is running rampant and you're living under a perpetual lockdown, I mean, people can see the astronomical cost to mental health. And in fact, I think that has led to a lot of resistance against lockdowns because people are seeing more the effect of mental health than actually the effect of COVID. I think, like, statistically, the mental health impacts are like 1 in 5 versus, say, 1 in 100 people dying from COVID. But what we have in Australia is something very different, which is that because our lockdowns were successful, we have the option to have short lockdowns that are costly in the short term, but then allow us to live long periods of time, not locked down, where then hopefully we can recover our mental health. And so I think in the COVID debate here, what's overlooked on the mental health component is in terms of making sure that really, like, individual particular restrictions that come in, whether or not they're an overburden on mental health relative to the amount that they spread COVID. And so I think one of the particular questions that comes up, I don't want to necessarily criticize it too much because I haven't seen the data on how much it prevents spread. But say, for example, banning two partners that don't live together from seeing each other at all, how much does that stop the spread of COVID versus the huge cost on loneliness, for example? And you could extend that out to say, should single people be allowed to have a friend in their bubble? Should parents that don't live together be able to still share the child? I think even when you think about mental health, and I would say that the cost of these lockdowns in the future is just going to be astronomical, far, far exceeding the short-term benefits. The difference, though, is that we can't do anything in the short term except fight COVID or not fight COVID. But in the long run, we can do all kinds of things to hopefully reverse the negative consequences on our health from having these lockdowns. And so I do think that on the whole, it's the most sensible thing to do. So yeah, hopefully that answers the question.
I think you have one more question you can answer, and I think we'll be out of time.
Okay, so I'll just answer. These are two short things. So health economics is a subcategory of economics, and you can't take a health economics major at USyd. You can take it as a specialized single subject, but we only have one undergraduate course on health economics.
Oh, that was very short. I think if that's the case, you may be able to fit the last question.
I'll take this other shorter one. Sorry about the person who asked a very deep question that we don't have time to answer. So what type of careers are available? So health economists work, in Australia, health economists can work in either the public or the private sector. So the kinds of things that you might do are help to make decisions about how Medicare chooses what to cover, what kinds of things are covered, how should we pay hospitals, and how do we work out how to pay hospitals? How do we decide what kinds of pharmaceutical products should be covered on the PBS? So questions about the management of our public healthcare system have a lot of jobs for health economists. And you can also work more broadly, particularly in consulting, in looking at how we should make decisions about where to allocate our dollars in terms of improving health. So should we put more money into education, or should we put more money into Medicare, so actual medical care? These kinds of questions often turn up more on, I guess, the private sector side in terms of consulting. Or you can, become a professor as well.
Wonderful. Thank you so much, Rebecca. It was a very interesting talk to learn about health economics, and especially with the current COVID lockdown we're going through, how it relates to economics overall. So thank you very much for a wonderful talk. If you can just stop share screen.
Yeah.
Thank you. I'm just going to post this evaluation link for everyone. We would like to know what you thought about the talk. It should take only 1 to 2 minutes to complete. So if you can participate, that will be fantastic. And also, I'm just going to share, there are few more articulate talk series coming up in term 3, starting from ancient history. We also have University of Sydney Virtual Open Day on Saturday, the 26th of August, Geography with Political Economy, and French talk in September. So if you are taking these subjects as well, please do join us. All right, so I'd like to thank Dr. Rebecca McKibbin for taking her time to talk about her specific areas of work she does at the University of Sydney. And we hope we'll be able to deliver something like this again in the future.